Hello and welcome to American Heart Association Science News. We're here at American Heart Association 2014 Scientific Sessions in Chicago. I'm Frederick Masoudi at the University of Colorado Anschutz Medical Campus, and I'm here with Mike Farkouh from the University of Toronto. We had the pleasure of moderating a session today called Clinical Trials Update, in which we discussed 4 specific clinical trials and had some great discussion around these. The first of these trials was the on-treatment analysis of the Improve It trial, a trial that's gotten a lot of attention here at AHA 2014. This was the on-treatment analysis of the use of a statin, simvastatin, versus a combination of simvastatin and ezetimibe in a secondary prevention setting. And this was, again, the on-treatment analysis. The intention to treat analysis was presented earlier this week. And what this on-treatment analysis found was that there was a significant, about 6% relative reduction in the risk of the composite endpoint of cardiovascular events with the treatment with the combination of these 2 drugs. Yeah. So this is a very interesting trial that makes us think a little bit more and expands our thinking about the treatment of dyslipidemia in patients, at least in the secondary prevention setting.
No, I agree, Fred, and I think that one of the important findings of this study is that it allows us to apply this to our higher risk patients. I think, first of all, the patients that really need to have intensification of lipid-lowering therapy. But the promise it holds is that we may be able to expand this to patients on lower doses of statins with ezetimibe alone. We need to understand that better. So I think that this will be, the beginning of the next round of studies. But what really impressed me was the fact that for every millimolar reduction in LDL, there was the same benefit of this combination therapy as we see with statins alone, which I think was compelling.
Yes, and I think this corroborates what the guidelines have been saying all along, which is that in the secondary prevention setting in particular, that a more intensive regimen is better. And this was a comparison of regimens of 2 different intensities, with the exception of the fact that this time now it was with an agent that to this point has not been proven to be associated with improved outcomes. And again, as you say, more remains to be seen about the other aspects of treatment and where this is most appropriately used.
Absolutely. Well, we also had the opportunity to hear from the West of Scotland investigators who a number of years ago published the primary prevention trial in males 45 to 65 who were, again, primary prevention patients randomized to pravastatin 40 milligrams versus placebo. And as you all may remember, at the 5-year mark, there was about a 30% reduction in major adverse cardiovascular events and trend towards reductions in cardiovascular death. This trial was further followed up for an additional 15 years now, for 20 years of follow-up. And what we have seen is perhaps a legacy effect of pravastatin in the patients treated in the original pravastatin arm compared to the placebo arm. And remember, at 5 years, these patients were crossed over to active medical therapy, or at least they had the option to have statin therapy. And what we found, in fact, was that only about 30% of patients were prescribed statins when they were eligible in the open phase of the trial as the trial ended. But in fact, there was still this ongoing reduction in events. So Fred, I don't know, have you seen this many times before in clinical trials?
All I can say is, first of all, no, there are not many clinical trials where you can say you can see 20-year follow-up, which is pretty remarkable. I do think the point you raised about the issue of about only a third of patients being on statins after the release of this, what was considered really, rightfully so, a landmark trial in the primary prevention setting, that only a third of patients that were eligible for enrollment in this trial ended up on a statin in the 5 years following the trial end date, which highlights a lot of these issues around how do we make sure that when we get a trial done, a successful trial like that, how do we do our best in integrating that information into practice as quickly as we can?
Absolutely. And I think, Fred, funding the follow-up of trials, the NHLBI and our funding agencies spend a great deal of resources to get the trial done. Seems like that just extra bit gives us so much more data. I'm excited about the opportunities in this trial.
The third trial that we discussed was an analysis of the TopCat trial, which is a randomized controlled trial of spironolactone versus placebo in patients with heart failure and preserved systolic function. Now, the primary results of this trial were presented last year at the American Heart Association Scientific Sessions. This year, the focus was on a marked heterogeneity in the patients and the outcomes as a function of where the patients were recruited in the trial. That is to say, the patients recruited in the United States and Western European countries, the risk profile was substantially higher in terms of adverse outcomes than it was for those patients recruited in Russia and Georgia. And there was also no perceptible treatment benefit if you looked at the subgroup analysis in the patients recruited in Russia and Georgia, perhaps in part because of the very low baseline event rate, and a very different story in the patients enrolled in the U.S. and Western Europe. So a lot to think about in terms of the conduct of trials. You know, a larger proportion of patients, for example, in Russia and Georgia were recruited on the basis of a prior heart failure hospitalization versus having positive biomarkers, raising some questions of, what did they really have, and is this really heart failure with preserved systolic function? So a lot to think about in the conduct and design of randomized controlled trials.
Fred, we've seen this now in a number of recent NIH trials. The concept of regional differences, and we're struggling with this. And sometimes we uncover strategies and processes of care that are different. But I think in this case it may be the eligibility criteria being different between the two regions, and of course there was this flexibility in the inclusion criteria. I also mentioned during the seminar the idea that we need to monitor the sites carefully to make sure that documentation is on par with what we would do in the United States. So I think there are a lot of lessons about international studies today.
Right. And unfortunately, although this was a negative trial on its primary endpoint with respect to the issue of heart failure with preserved systolic function, the use of spironolactone, I do have to say, again, kudos to the investigators for pulling this trial off. It's a very challenging population to study, and you have to congratulate them for at least bringing that study over the finish line. So it's a very difficult challenges that they faced. No question.
Well, the final study that was presented at our seminar was the secondary analysis from the DAP, the dual antiplatelet trialist trial. And if you remember, the primary analysis of this was presented a few days back in terms of drug-eluting stent subgroup, and the subgroup having drug-eluting stent, which was the primary analysis. This is now the analysis presented today was concerning the comparison of drug-eluting stents with bare metal stents, and then looking at the long-term findings in bare metal stent patients alone. And remember, the trial is a network study or trial in which patients who have had PCI with a stent are randomized to either at the 12-month mark to stop dual antiplatelet therapy or continue it through 30 months total of treatment with dual antiplatelet therapy. And interestingly enough, when they compared the drug-eluting stents to the bare metal stents in a propensity-matched analysis, which again is non-randomized, they demonstrated really no differences. Drug-eluting stents was a non-inferiority analysis, and it was found to be not non-inferior, I guess. So the issue is that they were quite similar, both drug-eluting stents and bare metal stents, which was a surprise to us. And then when they looked at the bare metal stent cohort, which was a much smaller subset of the patients, it looks like they also benefit in some equal ways proportionally with regards to longer-term dual antiplatelet therapy. So, Fred, your take on it?
Well, this was a really interesting group of analyses around this DAPT trial, which is a landmark trial in its own right. And the first part that you mentioned exactly is an observational study comparing the outcomes in bare metal versus drug-eluting stents. And although, of course, any of these sorts of things in observational context are potentially prone to confounding, these are very interesting results and somewhat challenge a bit our thinking about outcomes in these two populations. I think in general, the larger study is really going to potentially turn practice on its head and really make us rethink a great deal in terms of how long we're treating patients with dual antiplatelet therapy when they have coronary disease and have received a stent, at least.
That's right, and they've adjudicated the myocardial infarctions, and they're mostly due to spontaneous myocardial infarction and not due to stent thrombosis. So that means there's an ongoing benefit of this dinopyridines on top of aspirin. And I think the other idea is, when do we place a bare metal stent? When do we place a drug-eluting stent? This is also going to be turned on its head in terms of the preconceived notions about bleeding and risk of stent thrombosis and MACI or major adverse cardiovascular events. So, Fred, it was a pleasure to work with you, and I'll turn it over to you. You're the chair.
Thanks. Well, Mike, thanks so much. It was a pleasure co-chairing the session with you. Yeah. We heard about 4 very interesting trials. Always a pleasure to be at American Heart Association scientific sessions, learning a lot about how to make care better for our patients. So thanks for joining me.
Thank you.